morning to one and all. This is section regarding the management of drug-resistant TB, session 2. So in previous sessions we have seen what are all the various regimens available for drug-resistant TB. Now will give a overview on the pre-treatment evaluations and adverse reactions regarding the management of drug-resistant TB. So pre-treatment evaluations, this is very important and has significant role in the management of drug-resistant TB. So it includes both clinical as well as laboratory part as well as psychological part, that is counseling, that is also very important. So these are all various clinical, that is clinical evaluation which includes detailed clinical history of presenting symptoms as well as the previous TB treatment history, as well as anthropometric measurements like height, weight and body mass index and comorbidities and social habits and other psychiatric evaluations. Routine laboratory investigation which includes complete blood count with platelets, blood sugar, liver function test, HIV test, urine routine examinations and urine pregnancy test in the women of childbearing age groups, and other investigations like chest X-ray, audiogram, TSH. So again we will discuss this regarding the based on individual regimens. So additional evaluations sometimes may be needed, like a renal function test. If we are going to use any injectables like amino acids, ophthalmological evaluations for in case of using the linezolid, as well as thyroid test TSH, that is thyroid stimulating hormone if you are using ethionamide or PAS, mental health evaluation needed in case of cycloserines, like that serum electrolytes in case of bedaquiline. For H mono or poly drug resistant TB, the pre-treatment evaluation includes only history and physical examinations with height and weight, random blood sugar, chest X-ray and HIV testings. There is no additional investigations needed. But this pre-treatment counseling, this plays a major role like pre-treatment evaluations. We need to counsel the patients as well as family members regarding the what is DRTB, what impacts it will have both to the patients as well as to the those having a contacts. So we need counseling regarding the mode of spread, so how it can affect the others, and the treatment durations. This is very important regarding the what are the drugs going to use, and these what are the side effects of these drugs, as well as the duration of treatment and the toxic profiles, and all these things to be discussed in details before starting any treatment. And we need detailed counselings regarding the treatment of TB patients for better outcome. So also we need to give the how to prevent the disease transmissions like cough, etiquette measures, disposal of sputums, how to dispose the sputum collections, all these things to be told to the patients, as well as screening of close contacts for TB patients. This is also very important. And if female patients in the childbearing age groups, we have to counseling regarding the family plannings till the treatment is over. And these things, all counseling training modules has been available in the e-learning platform by NTEP. So supportive care is very important. This is like pulmonary rehabilitation. So this supportive care, we have to identify the comorbidities like which will adversely affect the treatment outcomes or adherence of treatment, like diabetes, liver and renal disease and neurological disease. Substance abuse like tobacco and alcohol use, we need a psychological counseling as well as frequent advice regarding the cessation of this substance abuse. as well as we can give some support schemes regarding to improve the socio-economic status of the patients, especially for TB patients, and nutritional assessment. So, we have to assess and give nutritional advice to the TB patients. And this is the patient follow-up, that is when for MDR or HDR TB patients, from diagnosis to till treatment, and even after that also patient has to be followed. So, whenever the initial patient comes, they first comes to the health facility, whenever they come to the first health facility, at that site itself we can diagnose whether it is DSTB or DRTB based on the NAT test. Suppose if it is diagnosed as DSTB, it has been managed at the primary health facility or community health officers, or there is private practitioners. They themselves can manage a drug sensitive TBs. Suppose if it is diagnosed as DRTB, that is drug resistant TB, especially rifampicin resistance, or that is MDR or RTB, these patient has been referred to their nearest DRTB centers to evaluate further with a second line LPA and as well as liquid culture sensitivity. After the diagnosis, they will initiate the treatment where we have a DRTB counselor will be available for patients, detailed counseling regarding the DRTB. They will give insight into the serious adverse reactions and the follow-up cultures, all these things they will take care, as well as the management of any adverse reactions. So, they will counsels regarding the patients on all these aspects. Once the treatment is initiated and the patient can be tolerated, they can again referred back to the primary care healthcare facilities where they can receive the medicines, they can be followed up. For any H mono or poly drug resistant TB which has been diagnosed by the community health officer or primary healthcare physicians or private practitioners. If it is H mono or poly drug resistant TB, they can themselves manage, but we have to give the samples for second line LPA as well as the liquid culture DST. If this shows additional resistance, so they have to refer to district TB centers, that is DRTB centers, for further evaluations, and they can be evaluated for pre-treatment evaluations, and they can start the treatment. Based on further resistance, they can modify treatment and referred back to the primary health system, primary care physicians again for follow-up. So, management of DRTB patients in consultation with the DRTB centers. So, the most important is the treatment adherence, because these drugs are, one is long durations and most of the drugs have some toxic profiles. So, the adherence is very important. Here plays the treatment supporters, and they have been even also given the incentives. So, they have to monitor the patients regarding the treatment adherence and whether they can take the medicines correctly and correct dose and correct ways. So, they can even use for ICT, that is information communication technology, to look after the adherence of the treatment by either calls or SMS reminders or IVR as electronic pill box, which has been introduced like 99 dots. So, they have some numbers after taking the pills, they can call that, or medication event reminder monitor. So, the adherence calendar also will be linked in the NICSHIs. So, we can provide provision of dashboards in NICSHI enables real-time customized access to DRTB data, enables efficient and effective monitoring of DRTB services. So, how to monitor the progress of DRTB during treatment? Suppose for shorter oral BDQ regimens. So, previously we discussed only 3 regimens are available in the program now. One is shorter oral BDQ regimens, another is longer oral MDR HDR TB regimens. The third one is H-mono poly-DRTB regimen. For shorter oral BDQ MDR regimen, the total duration will be the 9 to 11 months. That is initial 4 to 6 months IP and 5 months CP. Here the clinical and weight monitoring will be done monthly in the intensive phase, followed by quarterly in the continuation phase. Smear examinations will be, that is AFB smear examination monthly from the third month onwards in intensive phase, and extended IP if previous smear is positive. Whereas culture at the end of 3 months, 6 months and at the end of treatment. DST will be first line and second line LP and liquid culture DST. Culture positive means end of month 3 or later. If smear positive, end of IP or extended IP and the end of treatment. Whereas CBC with the platelets, as and when clinically indicated, it is not routinely indicated for shorter oral BDQ regimens. Whereas chest X-ray, thyroid test and liver function test need to be done at the end of intensive phase and end of treatment and whenever needed. ECG at the end of 2 weeks, then monthly IP, since it is BDQ containing regimens, monthly intensive phase, that is 4 to 6 months or as and when indicated. Serum electrolytes whenever clinically indicated, especially if there is QTC prolongations. Color vision test once in 2 months, especially in children, and urine pregnancy test as and when indicated. For longer oral MDR XDR TB regimen, the total duration will be the 18 to 20 months. Here there is no IP and CP. Here the clinical monitoring as well as weight monitoring will be monthly up to 6 or 7 or 8 months if previous smear is positive, and from quarterly in the month 7 or 9 month onwards. Smear test should be done within 7 days if any 6 month or later is positive to ascertain bacteriological conversions or reversions. Culture is needed monthly from month 3 onwards to end of if previous culture positive. Quarterly from month 6, 7 or 8 based on previous culture reports. So DST first line and second line LP and liquid culture DST if culture positive at the end of 6 months or any time beyond. Whereas complete blood counts with platelets needed at the end of 15 days and monthly in first 6 months if previous smear is positive at the end of 6 or 7, 8 months and as and when clinically indicated. So LFT to be done quarterly, TSH every 6 months and chest X-ray at the end of 6 months at the end of treatment and whenever indicated. ECG to be done at the end of 2 weeks, then monthly for first 6 months till BDQ, moxifloxacin, linezolid or delamanid is extended and as and when needed. Electrolytes again whenever needed, especially if there is any QTC prolongations. Urine pregnancy test as and when clinically indicated. For H-mono poly-DRTB regimens, the clinical monitoring as well as weight monitoring monthly till the end of treatment, smear monthly from month 3 till end of treatment, culture at the end of 3 months and end of treatment, and DST first line and second line LP and liquid culture DST if culture or smear positive at 3 months or end of treatment. All other investigations based on requirement only, but for color vision test do once in 2 months in children. So what are all the extension of intensive phase needed in what are all the regimens? For shorter oral BDQ regimen, we can extend the IP for 2 months. There is for longer oral MDR XDR TB regimen, we can extend the regimen, not IP, total regimen for 2 months, especially in pre-XDR and XDR TB patients or whenever the smear is positive or culture positive at the end of 6 months. H-mono or poly-DRTB regimens we can extend for 3 more months. So how to manage the treatment interruptions? Suppose any missed doses in the IP or CP, it should be completed prior to switching over to CP or stop the treatment. Only the missed doses. Suppose if it's missed less than 2 months durations, the regimen to be continued and duration of treatment to be extended to complete the IP or CP. Suppose if missed more than 2 months continuously, that is lost to follow, do repeat evaluation with the NAT test and first line, second line LPA, DST and restart the DST based treatment. For bedaquiline, suppose if missed bedaquiline in first to 2 weeks of course, if it is the less than 7 days missed, continue the regimen and duration of treatment extended to complete IP. If more than 7 consecutive days, bedaquiline course has to be restarted and send the specimen for culture. So, if BDQ missed in 3 to 24 weeks of treatment, if it is missed dose, it will be less than 2 months. Do not make up for missed dose, continue the schedule and send the culture. So, that is no need to extend the BDQ. If more than 2 months, that is labeled as lost to follow, discontinue the regimen, start fresh longer regimen with the based on the culture reports. So, there are some adverse effects of drugs which has been used in the DRTB managements, and these things are already well known for everybody's, like kanamycin and capreomycin have nephro and ototoxicity, and the quinolones have arthralgia, dizziness, convulsions, diarrhea, vomiting and abdominal symptoms and phototoxicity with QTC prolongations. Ethionamide again have abdominal discomfort, epigastric discomfort, anorexia, vomitings. Sometimes they have hepatitis, hypothyroidism. So, patient has to be evaluated for TSH, those on ethionamides. Neuropathy and gynecomastia are also some of the side effects. Cycloserine need psychological counseling as well as psychological evaluations to look for confusion, depression and suicidal tendency, insomnia and seizures. PAS again have abdominal discomfort with anorexia and nausea, hepatic dysfunctions as well as hypothyroidisms. Linezolide have myelosuppression, so we have to look for CBC, especially hemoglobin and platelet counts, and look for peripheral neuropathy as well as optic neuritis and lactic acidosis. So, patient on linezolide need ophthalmic evaluations, especially for children. Clofazimine have skin discoloration and as well as QTC prolongations. Bedaquiline, the main side effect will be the QTC prolongations as well as with nausea, vomiting, hepatitis, elevated amylase, lipase, and arthralgia and headache. What is the role of surgery in MDR, XDR TB patients? So, surgery will be offered only in the unilateral resectable disease only in the following situations. When there is absence of response to treatment with effective anti-TB drugs despite 6 to 9 months of regular treatment, morbid complications of parenchymal disease like uncontrolled hemoptysis or bronchiectasis with recurrent infections, reversion of culture to positive during treatment, relapse after treatment completions, high risk of failure or relapse, that is high degree of resistance or parenchymal involvement. In these scenarios only surgery will be undertaken. What are the various outcomes in the RR, MDR and XDR TB treatment? For treatment success, we have two outcomes, either cured or completed. Cured is defined as treatment completed as recommended without evidence of failure and 3 or more consecutive cultures taken at least 30 days apart during CP or negative, including one at the end of treatment. Whereas treatment completed is defined as treatment completed as recommended without evidence of failure, but there is no record that 3 or more consecutive cultures taken at least 30 days apart are negative after IP. So, these two consider as treatment success. For shorter MDR TB regimens, cured is defined as treatment completed as recommended without evidence of failure and culture negative at the end of treatment and one culture at least on previous occasion. Whereas completed is defined as treatment completed according to guidelines but does not meet the definition of cure or treatment failure due to lack of microbiological results. So these two outcomes will be considered as success. Whereas other treatment outcomes like failure, died, lost to follow-up, not evaluated. So failed is defined as treatment terminated or need for permanent change to new regimen or treatment strategy because of lack of clinical or bacteriological response, that is bacteriological conversion with no reversion, or adverse drug reactions or additional acquired resistance to FQ and second line injectables. Died. Any patients who dies for any reason during course of treatment is labeled as died, irrespective of cause, could be TB or non-TB. Lost to follow-up. A patient whose treatment is interrupted for more than 2 consecutive months or more is considered as lost to follow-up. A patient for whom no treatment outcome is assigned is labeled as not evaluated. What is conversion? What is reversions? Conversion to negative, that is 2 consecutive cultures taken at least 7 days apart or negative is labeled as conversion. Reversion to positive, that is 2 consecutive cultures taken at least 7 days apart or positive after initial conversion. So even after completion of treatment for DRTB, they have to be followed up at the 6, 12, 18, 24 months after completion of treatment if symptomatic by clinical evaluations with chest X-ray, smear, culture and DST if culture is positive. So palliative care, this is very important for DRTB patients as well as post-DRTB patients. So this is often played very less role and in the program. So we have to concentrate more on these palliative care aspects because they are, especially chronic TB patients, they are very chronically ill with extensive disease, failed XDR, TB or mixed pattern drug resistant regimens. Regimen cannot be designed with the new drugs. So here the respiratory rehabilitation, that is pulmonary rehabilitation, plays a major role. So they have to be relieved from the symptoms, that is to be given as a prime importance. At the same time, they have to follow the infection control measures. So to prevent the spread of DRTB to close contacts, they have to be given a nutritional support with nutritional advice and supplements, and they have better occasional rehabilitation to get better socioeconomic status, and the preventive measures to prevent the spread of disease to others, and they need a psychosocial support also. So the treatment of MDR, XDR TB or whatever may be the drug resistant TB is challenging one because of duration of treatment with the poor drug adherence, combination of multiple drugs, poor efficacy, some of the drugs have maybe have less efficacy, and toxics as well as expensive, and there is no FDC available for DRTBs at present. So what are all the factors which influence the TB treatment outcomes, which has been well known for long periods. So even the program of PMDT has been available, this has been rolled out for long. So this again takes 3 parts. One is healthcare providers, the next is programs, that is drugs, third is patient's perspective. So regarding the healthcare providers, it is we have to ensure the non-compliance, we have to look for non-compliance with the guidelines, lack of proper trainings, poor patient educations, not monitoring the treatment outcomes, poor management of ADRs and poor treatment support. This is from the healthcare providers. Suppose drugs, poor quality of medicines, unavailability, that is uninterrupted supply, we need uninterrupted supply of medicines, poor storage conditions, wrong dose or combinations, and poor regulations of medicines use. So patient's perspective, lack of information regarding the DRTB and lack of means to adhere to treatment because of adverse effects, social and financial barriers, substance abuse or dependence, and comorbidities like HIV, diabetes, or undernutrition and malabsorption. So, drug resistance is always preventable. We all three, so that is programs, patients, as well as healthcare providers, combined hands together to prevent the drug resistance. So, prevention of drug resistance is a priority one. Treatment of DRTB is less effective, more prolonged, expensive, and toxic compared to DSTB. So, the minimum duration of treatment is 9 to 18 months. The dosage of drug is based on body weights. Pre-treatment counseling plays a major role. Monitoring treatment progress and drug adverse reaction is also important. So, we need much more newer drugs and newer shorter regimens for the benefit of patients and society. Thank you.